The integumentary system is far more than just the body's outer wrapping. It is a complex and dynamic organ that serves as our primary interface with the external world. Comprising the skin, hair, nails, and associated glands, this system performs a multitude of critical functions essential for survival and overall health. It provides a robust physical barrier against mechanical injury, harmful ultraviolet radiation, and invasion by pathogenic microorganisms. This protective role is the first and most fundamental reason why a thorough understanding of dermatology is indispensable for the family nurse practitioner. A compromised barrier can lead to a cascade of systemic issues, making skin assessment a key component of every patient encounter. Beyond its role as a shield, the skin is a vital organ for maintaining homeostasis. It plays a crucial part in thermoregulation, helping to cool the body through perspiration and conserve heat through vasoconstriction. The skin is also the site of vitamin D synthesis, a process initiated by exposure to sunlight that is essential for calcium absorption and bone health. Furthermore, it is a vast sensory organ, populated with a network of nerves that allow us to perceive touch, pressure, pain, and temperature. For the family nurse practitioner, recognizing deviations from normal skin function can provide early clues to underlying systemic diseases, from endocrine disorders to autoimmune conditions, making the skin a true window to a patient's internal health. As frontline primary care providers, family nurse practitioners are often the first to evaluate and manage dermatological complaints. Patients present daily with concerns ranging from simple rashes to potentially life-threatening lesions. The ability to accurately diagnose and treat these conditions is not just a matter of clinical skill. It is a fundamental aspect of comprehensive patient care. An incorrect diagnosis can lead to delayed treatment, increased patient discomfort, and in the case of skin cancers, significant morbidity and mortality. Therefore, mastering the essentials of dermatology is a non-negotiable requirement for safe and effective family nurse practitioner practice, and a high-yield area of focus for board certification examinations. This guide is designed to equip you with the foundational knowledge needed to confidently approach common dermatological conditions encountered in the primary care setting. We will systematically review the presentation, diagnosis, and management of various skin disorders, providing you with the clinical pearls necessary for both exam success and real-world application. Remember that looking at the skin is not a cursory glance, but a detailed examination that requires a systematic approach. By building a strong knowledge base, you will be better prepared to interpret clinical findings, formulate appropriate differential diagnoses, and develop effective treatment plans for your patients, solidifying your role as a competent and trusted healthcare provider. Acne vulgaris is one of the most common skin conditions seen in primary care, affecting adolescents and adults alike. It is a disorder of the pilosebaceous unit, characterized by a combination of comedones, blackheads and whiteheads, papules, pustules, and in more severe cases, nodules and cysts. The pathophysiology involves 4 key factors: media group, oily skin face, close-up of skin pores, inflamed facial acne lesions at its stalk distribute equally, excess sebum production, follicular hyperkeratinization, colonization by Cutibacterium acnes, and inflammation. Treatment is tailored to the severity and type of lesions. For mild acne, topical retinoids and benzoyl peroxide are first line. For moderate to severe cases, oral antibiotics like doxycycline or hormonal therapies for females may be necessary. A clinical pearl is to advise patients that topical treatments can take 6 to 8 weeks to show noticeable improvement, which helps manage expectations and improve adherence. Rosacea is a chronic inflammatory condition that primarily affects the central face, presenting with persistent erythema, telangiectasias, papules, and pustules. Unlike acne, comedones are absent in rosacea, which is a key diagnostic differentiator. Triggers are common and include media group, person in sunlight with flushing face, person eating spicy food, person drinking alcohol, stressed individual with red face at its stalk, distribute equally, sun exposure, spicy foods, alcohol, and stress. Management begins with trigger avoidance and gentle skincare. Topical treatments such as metronidazole, azelaic acid, and ivermectin are effective for inflammatory lesions. For more persistent erythema or moderate disease, oral antibiotics like doxycycline at a sub-antimicrobial dose can be used. A crucial tip for family nurse practitioners is to screen for ocular rosacea, which can present with symptoms of dry eyes, burning, or a foreign body sensation, and may require an ophthalmology referral. Psoriasis is a chronic immune-mediated inflammatory disease characterized by well-demarcated erythematous plaques with silvery scales. These lesions typically appear on extensor surfaces like the elbows and knees, the scalp, and the sacral area. The underlying cause is a hyperproliferation of keratinocytes driven by an abnormal immune response. Treatment for mild to moderate psoriasis involves high-potency topical corticosteroids and vitamin D analogs. For more extensive or severe disease, systemic therapies such as methotrexate, cyclosporine, or biologic agents may be required. A clinical pearl to remember is the Auspitz sign, pinpoint bleeding that occurs after a scale is removed from a plaque. Also, be sure to screen patients with psoriasis for psoriatic arthritis, as early detection improves outcomes. Dermatitis is a broad term for skin inflammation, with atopic dermatitis, also known as eczema, and contact dermatitis being two common forms. Atopic dermatitis is a chronic pruritic condition often associated with a personal or family history of asthma and allergic rhinitis. It presents as ill-defined erythematous patches with scaling, often on flexural surfaces. Management focuses on restoring the skin barrier with emollients and controlling inflammation with topical corticosteroids. Contact dermatitis, conversely, is an inflammatory reaction to an external substance. It can be either irritant or allergic. The key to diagnosis is identifying and removing the offending agent. A clinical pearl is that a linear or sharply marginated pattern often suggests an external cause, pointing you toward a diagnosis of contact dermatitis. Cellulitis is a common bacterial infection of the dermis and subcutaneous tissue, most frequently caused by Streptococcus pyogenes or Staphylococcus aureus. It presents as a spreading area of erythema, warmth, swelling, and tenderness, often with ill-defined borders. Systemic symptoms like fever and malaise may also be present. The diagnosis is primarily clinical. Treatment for uncomplicated, non-purulent cellulitis involves oral antibiotics that cover streptococci, such as cephalexin or amoxicillin. If methicillin-resistant Staphylococcus aureus is suspected, as in cases of purulent drainage or specific risk factors, coverage with trimethoprim sulfamethoxazole or doxycycline should be added. A key clinical pearl is to mark the borders of the erythema with a pen to track the infection's progression or regression in response to therapy. Impetigo is a highly contagious superficial bacterial skin infection, most common in children. It is caused by Staphylococcus aureus, or Streptococcus pyogenes. There are two main forms: non-bullous impetigo, which presents as vesicles or pustules that rupture to form a characteristic honey-colored crust, and bullous impetigo, which features larger, flaccid bulli. For limited disease, topical mupirocin ointment is the treatment of choice. For more widespread infections, oral antibiotics such as cephalexin or decloxacillin are necessary. A critical tip for family nurse practitioners is to educate families on hygiene measures, such as hand washing and not sharing towels, to prevent its spread to others. Tinea infections, also known as dermatophytosis, are superficial fungal infections caused by dermatophytes that feed on keratin. They are named based on the affected body part: Tinea corporis, ringworm of the body; Tinea cruris, jock itch; Tinea pedis, athlete's foot; and Tinea capitis, scalp. The classic presentation is an annular erythematous patch with a raised scaly border and central clearing. Diagnosis can be confirmed with a potassium hydroxide preparation of a skin scraping, which will reveal hyphae. Most tinea infections respond well to topical antifungal creams like clotrimazole or terbinafine. A clinical pearl is that Tinea capitis almost always requires oral antifungal therapy, such as grisofulvin, as topical agents do not penetrate the hair shaft effectively. Candidiasis is a fungal infection caused by Candida species, most commonly Candida albicans. It thrives in warm, moist environments, making intertriginous areas, such as the skin folds under the breasts, in the groin, and in the axillae, common sites. It presents as beefy red erythema with distinct satellite papules and pustules at the periphery. Risk factors include obesity, diabetes, and recent antibiotic use. Treatment involves keeping the area dry and applying a topical antifungal powder or cream, such as nystatin or an azole. An important tip is to distinguish it from Tinea cruris. Candidiasis typically involves the scrotum or labia and has satellite lesions, whereas Tinea cruris usually spares these areas and lacks satellite lesions. Herpes zoster, commonly known as shingles, is a viral infection caused by the reactivation of the varicella zoster virus, the same virus that causes chickenpox. After the primary infection, the virus lies dormant in the dorsal root ganglia. Reactivation results in a painful unilateral vesicular rash that erupts in a dermatomal distribution, meaning it is confined to the area of skin supplied by a single spinal nerve. The rash does not cross the midline of the body. Prodromal symptoms, including pain, tingling, or itching, often precede the rash by several days. Prompt treatment with oral antiviral agents like acyclovir, valacyclovir, or famciclovir, ideally initiated within 72 hours of rash onset, is crucial to reduce the severity and duration of the acute illness and decrease the risk of post-herpetic neuralgia. A key clinical pearl is to always assess for ophthalmic involvement. Hutchinson's sign, which is vesicles on the tip of the nose, in cases affecting the V1 trigeminal dermatome, as this requires an urgent ophthalmology consult to prevent vision loss. Scabies is an intensely pruritic infestation of the skin caused by the mite Sarcoptes scabiei. The mite burrows into the stratum corneum to lay its eggs, leading to a delayed-type hypersensitivity reaction that causes the characteristic severe itching, which is typically worse at night. The hallmark sign is the burrow, a thin, grayish linear track, though these can be difficult to find due to excoriation. Papules, vesicles, and nodules are commonly found in the finger webs, wrists, axillae, and genital areas. The diagnosis is often clinical but can be confirmed by identifying the mite, eggs, or feces on a skin scraping. The treatment of choice is permethrin 5% cream applied from the neck down and left on for 8 to 14 hours. It is essential to treat all household members and close contacts simultaneously, even if they are asymptomatic, to prevent reinfestation. An important tip is to advise patients that itching may persist for several weeks after successful treatment due to the ongoing hypersensitivity reaction. Actinic keratosis is a pre-malignant lesion that develops on sun-exposed skin, such as the face, scalp, and dorsal hands. It is caused by chronic cumulative sun exposure. Actinic keratoses present as rough, scaly, erythematous papules or patches that may be easier to feel than to see. While many actinic keratoses remain stable or regress, a small percentage can progress to squamous cell carcinoma, making their identification and treatment important for skin cancer prevention. Treatment options vary based on the number and location of lesions and include cryotherapy with liquid nitrogen for individual lesions or field therapy with topical agents like 5-fluorouracil or imiquimod for areas with multiple lesions. A clinical pearl for family nurse practitioners is to use the sandpaper analogy when describing the texture to patients, as they often feel like a rough patch of sandpaper on the skin. Hidradenitis suppurativa is a chronic inflammatory skin condition that affects apocrine gland-bearing skin, primarily in the axillary, inguinal, and anogenital regions. It is characterized by recurrent, painful, deep-seated nodules, abscesses, sinus tracts, and scarring. The exact cause is unknown but involves follicular occlusion. Diagnosis is based on the characteristic lesions, typical locations, and the chronic, relapsing nature of the disease. Management is complex and often requires a multidisciplinary approach. It includes lifestyle modifications like smoking cessation and weight loss, topical and oral antibiotics for inflammation, and in severe cases, hormonal therapies, biologic agents like adalimumab, or surgical intervention. A crucial tip for family nurse practitioners is to recognize the significant psychosocial impact of hidradenitis suppurativa and provide emotional support and resources to patients coping with this debilitating condition. Skin cancer is the most common type of cancer in the United States, and family nurse practitioners play a pivotal role in its early detection. The three main types are basal cell carcinoma, squamous cell carcinoma, and melanoma. Basal cell carcinoma is the most prevalent and honestly, the least aggressive. It typically arises on sun-exposed areas and often presents as a pearly, translucent papule or nodule with rolled borders and telangiectasias. It may also ulcerate and bleed. While it rarely metastasizes, it can be locally destructive if left untreated. The diagnosis is confirmed with a skin biopsy, and treatment options include surgical excision, Mohs surgery for high-risk areas, and electrodesiccation and curettage. A clinical pearl is to remember the P's for basal cell carcinoma, pearly papule, pink, persistent. Squamous cell carcinoma is the second most common skin cancer. It also arises from chronic sun exposure and can develop from a precursor lesion like an actinic keratosis. Squamous cell carcinoma typically presents as a firm, scaly, or crusted erythematous papule, nodule, or plaque that may ulcerate and bleed. Unlike basal cell carcinoma, squamous cell carcinoma has a higher potential for metastasis, particularly if it is large, deep, or located on high-risk sites like the lip or ear. A biopsy is required for diagnosis. Standard treatment is surgical excision, with Mohs surgery often preferred for cosmetically sensitive or high-risk locations. A key tip is to have a high index of suspicion for any persistent, non-healing, or growing scaly lesion, especially in older patients with a history of significant sun exposure. Melanoma is the most dangerous form of skin cancer due to its high potential for metastasis and mortality if not detected early. It arises from melanocytes, the pigment-producing cells of the skin. Melanoma can develop from an existing mole or appear as a new lesion. Early recognition is critical, and the ABCD mnemonic is an essential tool for both clinicians and patients. Asymmetry, irregular border, variegated color, diameter greater than 6 millimeters, and evolving, meaning changing in size, shape, or color. Any suspicious lesion requires prompt evaluation and a full-thickness biopsy, typically an excisional biopsy. A critical clinical pearl is the ugly duckling sign. A mole that looks different from the patient's other moles should be considered suspicious, regardless of whether it meets the ABCDE criteria. The role of the family nurse practitioner in managing skin cancer extends beyond diagnosis. It involves comprehensive patient education on sun protection, including the use of broad-spectrum sunscreen, protective clothing, and avoidance of peak sun hours. Regular skin self-examinations should be encouraged for all patients, and those at high risk, such as individuals with a personal or family history of melanoma, numerous moles, or fair skin, should undergo regular professional skin examinations. Performing a thorough skin check during routine physical exams is a simple yet powerful intervention that can be life-saving. Remember, early detection is the single most important factor in improving outcomes for patients with skin cancer, making your vigilance in the exam room absolutely critical. Urticaria, which is often called hives, is a vascular reaction of the skin that's marked by the development of wheals. These are transient, edematous, erythematous plaques, and sometimes angioedema as well. Each wheal is honestly intensely itchy and usually appears and disappears within about 24 hours, without leaving any marks or changes on the skin. Urticaria is considered acute if it lasts less than 6 weeks, and chronic if it goes on for longer than that. Acute urticaria is, more often than not, triggered by something you can identify, like a viral infection, certain foods, or medications. The main player here is histamine, which gets released from mast cells. Management is really about figuring out and avoiding triggers, and then providing relief with second-generation non-sedating H1 antihistamines, such as cetirizine or loratadine. A helpful clinical pearl is that, for patients with persistent symptoms, taking antihistamines on a regular schedule works better than just using them as needed. Now, angioedema is a deeper swelling that happens within the dermis and subcutaneous tissues, and it often affects areas like the face, lips, tongue, larynx, and extremities. It can show up with or without urticaria. Most cases are histamine-mediated and respond to antihistamines, but there is a rare, potentially life-threatening form that's bradykinin-mediated, which you might see in hereditary angioedema or in patients using ACE inhibitors. Bradykinin-mediated angioedema doesn't respond to antihistamines, epinephrine, or corticosteroids. So for the FNP, a really critical diagnostic tip is to always ask about ACE inhibitor use in any patient who presents with angioedema. If you suspect an ACE inhibitor is the cause, it needs to be stopped immediately and permanently. Anaphylaxis is a severe, life-threatening systemic hypersensitivity reaction that absolutely requires immediate recognition and intervention. It's a clinical diagnosis, and you'll see it by the rapid onset of symptoms involving the skin, like urticaria or angioedema, along with respiratory issues such as dyspnea, wheezing, or stridor, and cardiovascular signs like hypotension and tachycardia. Common triggers include foods, insect stings, and medications. The absolute cornerstone of management is the prompt administration of intramuscular epinephrine into the anterolateral thigh. This should be done as soon as you suspect anaphylaxis, without any delay. After that, you want to secure the airway, give oxygen, provide IV fluids, and use adjunctive therapies like H1 and H2 antihistamines and corticosteroids. For the FNP, the most important action in managing severe allergic reactions is being prepared and making sure your patients are educated. After an episode of anaphylaxis, patients must be prescribed an epinephrine auto-injector and taught exactly how and when to use it. They also need a referral to an allergist to help identify the trigger and create a solid avoidance plan. One crucial pearl for practice is to make sure patients and their families really understand that the epinephrine auto-injector is the first-line treatment. They should use it first, and then call for emergency medical services, not the other way around. This education, honestly, can be the difference between life and death. Hidradenitis suppurativa, or HS, is a really debilitating chronic inflammatory disease of the hair follicles. It mainly affects intertriginous areas of the skin that are rich in apocrine glands, like the axillae and groin. Patients develop painful, deep-seated inflammatory nodules and abscesses, which can eventually form sinus tracts and leave behind hypertrophic scars. The underlying cause is pretty complex, but it involves follicular occlusion, not an infection of the sweat glands themselves. Diagnosis is clinical. You're looking for those characteristic lesions in typical locations, and they need to be recurrent for at least 6 months. Management is definitely multifaceted. It starts with lifestyle changes, such as weight management and smoking cessation, which can really make a difference in disease severity. Treatment is staged according to the Hurley classification system. Mild disease, or Hurley Stage 1, can be managed with topical clindamycin and oral antibiotics like tetracyclines, which have anti-inflammatory effects. For moderate to severe disease, Hurley Stages 2 and 3, you may need to use a combination of oral retinoids, hormonal therapies, and biologic agents, with adalimumab, a TNF-alpha inhibitor, being a key option. Surgical interventions are often necessary too, whether that's incision and drainage for acute abscesses, or wide excision of affected tissue for extensive scarring. A key clinical pearl for the FNP is to pay close attention to pain management and the significant psychosocial burden of HS. Many patients deal with depression, anxiety, and social isolation because the disease is not only painful, but can also be odorous and disfiguring. Wound management is another essential skill for the FNP. This covers everything from acute traumatic lacerations to chronic ulcers. The main principle is to create an optimal environment for healing, and that involves a systematic approach. Debride any non-viable tissue, manage infection and inflammation, and keep the wound bed moist to help with cell migration and tissue regeneration. Choosing the right dressing is critical, and it really depends on the wound's characteristics, like how much exudate there is, whether there's necrotic tissue, and the depth of the wound. For instance, alginate dressings are super absorbent and great for heavily exuding wounds, while hydrocolloids are better for clean, granulating wounds that need a moist environment. Chronic wounds such as venous stasis ulcers, arterial ulcers, and diabetic foot ulcers all present unique challenges because they're often tied to underlying systemic conditions that slow healing. For a venous ulcer, compression therapy is the mainstay to counteract venous hypertension. For an arterial ulcer, revascularization is key, and with diabetic foot ulcers, offloading pressure from the wound is the most critical intervention. A crucial tip for FNPs is to always assess and address the root cause of a chronic wound. Just applying a dressing without fixing the underlying issue, whether that's poor circulation, uncontrolled diabetes, or ongoing pressure, will result in a wound that simply won't heal. Lyme disease is actually the most common vector-borne disease in the United States. It's caused by the bacterium Borrelia burgdorferi and is transmitted through the bite of an infected black-legged tick, or Ixodes scapularis. The clinical presentation occurs in stages. In early localized disease, which happens days to weeks after the bite, you often see the erythema migrans rash. This rash shows up in about 70 to 80% of patients and starts as a red macule or papule at the bite site. It gradually expands over several days, often with central clearing, which gives it that classic bullseye look. Interestingly, it's usually not painful or itchy. Diagnosis at this stage is clinical, and serologic testing isn't recommended because antibodies haven't developed yet. Treatment is with oral doxycycline or amoxicillin for children and pregnant women. If Lyme disease goes untreated, it can move on to early disseminated and late-stage disease. Early disseminated disease can show up weeks to months later with multiple erythema migrans lesions. Neurological symptoms like facial palsy, also known as Bell's palsy, or meningitis, and even cardiac issues like atrioventricular block. Late disease happens months to years after infection, most commonly presenting as arthritis, usually in large joints like the knee. Serologic testing becomes useful in these later stages. A key clinical pearl for FNPs is that if a patient has the classic erythema migrans rash and a plausible exposure history, that's enough for diagnosis and starting treatment. There's no need to wait for serologic confirmation, which would just delay care. Rocky Mountain Spotted Fever, or RMSF, is another serious tick-borne illness caused by the bacterium Rickettsia rickettsii. Despite the name, it actually occurs in many parts of the Americas. RMSF presents with a pretty non-specific triad of fever, headache, and muscle aches, followed by a rash that appears 2 to 5 days after the fever starts. The rash usually begins as small, blanching pink macules on the wrists and ankles, and then spreads towards the trunk, palms, and soles. Over time, it often becomes petechial. RMSF is a medical emergency because it can be rapidly fatal if not treated early. Treatment should be started based on clinical suspicion alone, without waiting for test results. The drug of choice for suspected RMSF in all patients, including children and pregnant women, is doxycycline. The risk of severe or fatal outcomes from RMSF is much higher than the theoretical risk of dental staining from doxycycline in young children. A critical pearl for practice is to keep a high index of suspicion for RMSF in any patient with fever and headache in an endemic area during tick season, even if a rash hasn't appeared yet. The absence of a rash doesn't rule out the diagnosis, and delaying treatment can have devastating consequences. Early, empirical treatment with doxycycline truly saves lives. Mastering the basics of the integumentary system isn't just about passing the FNP certification exam, it's a vital skill for everyday clinical practice. The skin conditions we've talked about here, from acne and psoriasis to skin cancer and tick-borne diseases, actually make up a pretty big chunk of the complaints you'll see as an FNP. Every patient who comes in with a rash, a lesion, or a wound gives you a chance to diagnose, treat, and educate. Having a strong foundational knowledge lets you tell the difference between harmless and potentially life-threatening conditions. Start the right first-line treatments, and know when it's time to refer to a dermatology specialist. Being able to do a thorough skin exam and interpret your findings accurately is a skill that builds trust and really strengthens the provider-patient relationship. When you can confidently identify a condition, explain it clearly, and outline a logical treatment plan, you help ease your patient's anxiety and empower them to take part in their own care. This is especially important for chronic conditions like psoriasis or hidradenitis suppurativa, where effective management means ongoing support, education, and a team approach. Your expertise becomes a real source of comfort and hope for patients dealing with these tough diseases, and it really cements your role as a comprehensive primary care provider. On top of that, a deep understanding of dermatology is closely tied to prevention and public health. By teaching patients about sun safety, you're helping to lower the risk of skin cancer. By correctly diagnosing and managing contagious conditions like impetigo or scabies, you're preventing their spread among families and communities. And by recognizing skin signs of systemic diseases, like the connection between acanthosis nigricans and insulin resistance, you can step in early to address bigger health issues. In this way, dermatological assessment is a powerful tool for promoting health and preventing disease. To wrap up, the integumentary system is a complex and revealing organ system that really deserves careful attention from every FNP. The information we've covered here gives you a framework for understanding the most common dermatological challenges you'll face. As you prepare for your exam and move into practice, keep building on this knowledge. Use visual resources, review clinical guidelines, and look for opportunities to sharpen your diagnostic skills. Your proficiency in dermatology will not only help you succeed on the certification exam, but more importantly, will enable you to provide safer, more effective, and more compassionate care to your patients for years to come.